So if there is organ involvement, we tend to use cyclophosphamide, mycophenolate, calcineurin inhibitors, targeted therapies, or biologics. And since there are some aspects of lupus where patients cannot take all the agents that would be best for them, we sometimes enroll them in clinical trials. About half, as I mentioned with SLE, have organ-threatening disease. Most common is kidney. Second most common is low platelets. Third would be central nervous system. But one must also be aware that lupus can affect the lungs with the interstitium or cause pneumonitis. It can affect the liver, produce retinal vasculitis, myocarditis, microvascular angina, mesenteric vasculitis, and sometimes more serious complications such as TTP. Disease activity predicts how one is going to do. There is something called the SLIC, and those who have higher activity tend to have a greater mortality and increase in damage score. We try to restrict this. For lupus in the kidney, which is seen at some point in a third of all patients, it's usually manifest by urine protein excretion, which leads to low albumin and edema, especially in nephrotic ranges, a sediment which can include red cell casts, granular casts, hyaline casts, white cell casts, and decreased renal function and hypertension. The American College of Rheumatology guidelines for monitoring lupus nephritis activity include looking at urine, blood pressure, kidney function, complements, anti-DNA, and protein creatinine ratios. And on the basis of that, we usually determine treatment, which can include, in most cases, prednisone, mycophenolate, and sometimes calcineurin inhibitors, rituximab, and azathioprine, or some of the newer biologics that are being studied. For involvement of the heart, we have a large menu of involvement. We've already talked about serositis. Some people can have myocarditis or congestive heart failure. 25% with SLE have hypertension. About 2% have actual vasculitis, which is intimal proliferation, medial necrosis, and adventitial fibrosis of the coronary vessels. One can get valvular deposits without infection, such as Liebman-Sachs endocarditis, or with infection, where you actually do develop endocarditis. The problem with endocarditis is that these deposits can fleck off and become thromboembolic. Valvular insufficiency is not uncommon, and as a consequence, lupus patients have a 7 to 10-fold increased risk of coronary heart disease and stroke. In the lung, in addition to pleurisy and susceptibility to infection that we've mentioned, one can bleed into the lung, scar the lung, acutely inflame the lung, or chronic pleurisy can lead to diaphragmatic atrophy with adhesions and scarring that produces something called interstitial shrinking lung syndrome. About 10% or less with SLE develop pulmonary emboli, and pulmonary hypertension is seen in approximately 10% with SLE. Neuropsychiatric manifestations range from acute inflammation in the brain to organic brain syndrome to seizures, headache, focalized manifestation. One can also get involvement of the peripheral nervous system as well.